Alright guys, we're back for a Heme Week 2 review. We've got a new theme band this week. It's U2. Pearl Jam was last week. So let's dive right into it. Try to make this as quick and efficient as possible for you all. Alright, so overview of platelets. This diagram down here is just an overview of the developmental pathway in the bone marrow. Megakaryocytes develop and then basically die and all split up and produce these little platelet fragments. Platelets are involved in primary hemostasis, so that's the initial plug formation. Secondary hemostasis refers to the coagulation cascade that produces fibrinogen that kind of binds, forms this fibrin mesh over the platelets and solidifies the plug. So platelet clotting involves 3 steps: the initial adhesion to the damaged wall, activation of the platelets that causes the conformational shape, and aggregation of the platelets together to form the clot. So platelet function, just a few of these things. I have a diagram that I'll show you guys, but this one here shows it as well. You see the surface proteins that are expressed. Platelets have a lot of surface proteins, but here are a few of the main ones. GP1B, that binds von Willebrand's factor, which links to collagen, and GP2B3A, so that induces cross-linking to fibrinogen. Alpha granules in the platelets have many activating factors, including von Willebrand's factors and serotonin and other factors as well. Dense granules are the main granules that have ADP, which also causes platelet activation. So the overall pathway, when you get an injury, you have exposed endothelium, you get vasoconstriction, and other decreased nitric oxide, prostacyclin, and increased endothelin, which also cause the vessel to constrict. So basically just to minimize blood loss, the exposed collagen, tissue factor, von Willebrand release from the endothelium, all lead to platelet adhesion, either directly or linking to von Willebrand's. And as these platelets bind, they become activated. ADP release, they're activated through these local factors, as well as binding, causing this shape change, and the granules release. This kind of, all these factors can recruit more platelets, and you get this initial plug. The activated platelets change their shape. They become, membranes become, instead of round, they have this really irregular, weird shape that allows them to have more surface area for binding to more platelets. So this is just a close-up of this diagram. So the GP2B3A deficiency is in Glanzmann thrombocytopenia, cross-links to fibrinogen. ADP release from the dense granules causes this GP2B3A to be expressed. GP1B cross-links collagen in the basement membrane here to via von Willebrand's factor. And you get a deficiency of GP1B in Bernard-Soulier, and in von Willebrand's you can get deficiency of von Willebrand's and von Willebrand's disease, which can be through a variety of mechanisms. But again, this is a similar pathway, but just showing some of the drugs that are involved, and we'll get into more of these later. But the important things to know, are just know the factors and the glycoproteins that are really involved either in drugs or some sort of disease. Otherwise, if there's a factor out there, you don't really need to know it for step 1, or the exam really either. But know what these various factors affect. Plavix blocks the ADP receptor, preventing expression of GP2B3A. These drugs block GP2B3A directly. The ristocetin assay activates von Willebrand's factor, so that allows you to differentiate Glanzmann's from Bernard-Soulier, which are two of the functional platelet disorders. So ristocetin assay is not going to work on Bardet because that acts through von Willebrand's and GP1B. Okay? Well, let's move on to the coagulation cascade. So we have the intrinsic and the extrinsic. Intrinsic is the tenet, so 12, 11, 9, 8, 10. You guys will go ahead and memorize this, but extrinsic is mainly monitored. It's affected a lot by warfarin. Remember, warfarin affects 2, 7, 9, and 10. And the INR, it checks the extrinsic pathway, so you can check warfarin levels with your INR. Remember, fibrin, soluble form of fibrinogen. When that's broken down, it forms a D-dimer. We'll talk about that a little bit later. So basically, if there's any clot formation, you're going to start to be breaking it down, and you're going to have an elevated D-dimer. Coag labs. So the platelet count, the basics. You want to see if you have either high or low platelets, which we'll also talk about. Remember, platelets can be elevated if you just have some sort of stress, inflammatory, or infection. Normal is 150 to 450. Bleeding time, that's affected by the number and the function. So if you suspect some sort of platelet disorder, remember, in alcohol, liver disease, all sorts of other drugs can also affect the function of platelets. So that's also going to be important to know. Even if the platelet count is normal and someone has normal bleeding, you want to check a bleeding time. And then the PT, I text the extrinsic. So my PT is shorter than PTT. So extrinsic pathway is the short one. Hemolysis labs, a D-dimer that we talked about. Remember, D-dimer forms with any sort of clot. You're going to have an elevated D-dimer. So when you're thinking about PE, remember, if the person is sick for another reason, like if you're trying to figure out if this is developing pneumonia versus a PE, then you can still have an elevated D-dimer if there's like inflammation and stuff like that. So it's really poor specificity for a PE. It's good for ruling out if it's negative, but it's bad for ruling in if it's positive. So going on to platelet disorders, the thrombocytopenia can be through a number of different causes: decreased production, increased destruction, sequestration in the spleen, or dilutional, more rare. But if you have a massive transfusion of blood products, that usually packed RBCs don't contain a lot of platelets. So with the decreased production, so anything that's affecting the marrow, obviously, any toxic exposure that can cause, like a leukopenia or anemia can also cause a thrombocytopenia. Alcohol can do it, affect platelet maturation and production. HIV can also, I believe, cause an autoimmune thrombocytopenia, but it can also cause just a decreased production as well, affect the marrow. Destruction, so remember, platelet consumption in microangiopathies can be really dangerous because TTP and DSC especially can be devastating diseases. So you're definitely going to want to be concerned with that. Autoimmune, we're going to talk about ITP, but HIT also would kind of fall under this increased destruction category. So ITP, so autoimmune, you see a rapid fall in platelets it can be provoked by initial infection, but otherwise you're not really going to see any. They don't have HIV, they haven't started any new drugs. You want to rule these things out before diagnosing them with ITP. ITP is sometimes also used to be called immune, just because of the mechanism, but idiopathic thrombocytopenia purpura. You only really treat the thrombocytopenia if the platelets are very low. If you need to do a surgery, say you're splenectomizing them, then you probably want to give some of their platelets back. But mainly you treat them with steroids and immune modulators like rituximab and IVIG. So going on to thrombocytosis, you can get reactive thrombocytosis, like I mentioned. So if you have a cancer in general, like unrelated to bone marrow cancer, but just any sort of cancer, inflammation, like rheumatoid arthritis or lupus. If you get a splenectomy, this spleen normally sequesters some of the platelets, so you can get a reactive thrombocytosis after that. Essential ET, so you're going to get, that's part of the myeloproliferative disorder, so you can get a JAK2 mutation is what you're commonly going to see. You're going to see increased risk of bleeding and or thrombosis. Because the platelets aren't usually effective, so they can be abnormal, so they can have they can aggregate together and cause thrombosis, and they don't properly clot off, so you can have increased bleeding as well. So the classic for all the myeloproliferative disorders, you can see basophilia. So in CML, P. vera, other things, you can also, that's one of the things you want to watch for on your diff. So moving on to P. vera, you get the 4 H's, hypervolemia. Remember, back to your physiology days, red blood cells are osmotically active and they remain in the blood vessels, so you're going to get really high volume, you can get hypertension, you can get hyperviscosity. Remember, as you have increased number of O2, or increased number of RBCs, remember on that O2 saturation curve, you can get increased clotting just as the blood slows down, hyperuricemia, and you can get kidney stones and histamine release. So that's going to be the classic itching after a shower that you can sometimes see in step 1 questions. Budd-Chiari syndrome is really associated with these JAK2 mutations as well. In the labs, you're going to see an elevated hemoglobin hematocrit, but a decreased EPO, and that helps you differentiate from people who are blood doping and people who, say, have bad COPD and have low baseline oxygen levels. They're going to have, because they're trying to oxygenate their tissues, they're going to have high levels of EPO. They can have an increased hematocrit, but it's because of their baseline low oxygen. P. vera patients have normal oxygenation. So myelofibrosis, again, you can see this JAK2 mutation. Myelofibrosis is kind of on that spectrum that can progress to more malignant cells, because the marrow is getting kind of crowded out by this fibrosis. You can get massive splenomegaly and extramedullary hematopoiesis because the bone marrow is kind of being pushed out, and you can get an increase in platelets because of these mutations. CML, we're going to hopefully talk a little bit more about that later, but splenomegaly, very common, produced by the Philadelphia chromosome. You can get basophilia, you can get thrombocytosis, you can also get thrombocytopenia, but more commonly thrombocytosis, and a decreased leukocyte alkaline phosphatase score, because these are not effective leukocytes. They're defective leukocytes, malignant leukocytes that don't have an active LAP, like you'd see in a leukemoid reaction. So hypercoagulable states, you are at high risk of thrombosis. So the most common inherited thrombosis syndrome is factor V Leiden. That's just a mutated factor V that is hypercoagulable, causes clotting. Antiphospholipid antibody, classically associated with lupus. You can often, the clinical vignette is going to be recurrent miscarriages, without any genetic or other etiology that you can figure out. You can get arterial and venous thrombosis. The test causes you to have, although it's associated with thrombosis and not bleeding, it's associated with a prolonged PTT. So you're going to look at the labs. It's going to be someone who's had like these recurrent like strokes or DVTs or something like that, and it's not going to make any sense because they have a prolonged PTT. But it's because they have these autoantibodies that affect the lab. So these are the autoantibodies that you can have. Lupus anticoagulant and anticardiolipin can cause a falsely positive RPR as well. There are some other causes that you want to know at least the names of. You can also get antithrombin deficiencies, remember, if you have nephrotic syndrome, because you're peeing it out. And just always kind of on a clinical level, if someone's getting weird clots and you don't know why and they don't have one of these, think of some sort of underlying malignancy. It's a really common cause of hypercoagulability.